The symposium is titled COPD, New Vision or New Mirror Image.
Thank you. Good day. I would like to start the symposium or the presentation today by two thank you notes. The first one is for the LPS as an organizing committee and as a society in a whole, and especially to the scientific committee for organizing such a very interesting meeting. My second thank you goes to AstraZeneca for two reasons. First, to organize and sponsor the symposium, and second, for being very generous to allow me to present a presentation completely marketing-free and without any drug-specific promotional material. So we're talking about COPD. This is an old quote from the Williams Book of Medicine that at least our professors learned in it, and we continue to learn in the newer version, I hope. It's a disease on which a good deal of wholly unmerited sympathy is frequently wasted. It is a disease of the gluttonous, bibulous, otiose, and obese, and represents a well-deserved nemesis for the unlovely indulgence. So this is how negative we used to look at the patient with COPD. It's worth mentioning that there was a study done by Renard in the US in the or the early 2000s, which thought that 61% of the COPD patients believe that their doctors think it is their own fault and they deserve what they have. That's pretty interesting. Okay. So now we are expanding the definition of COPD, and this is from the 2006 GOLD, not the most recent one. Now, COPD is a preventable, treatable, and characterized by airflow limitation that is not fully reversible and is usually progressive and associated with an abnormal inflammatory response. Prior to that, COPD was more nihilistically described as being a disease state characterized by the presence of airflow obstruction due to chronic bronchitis or emphysema, generally progressive, and may be accompanied by airflow hyperactivity and may be partially reversible. Much more negative vision into the disease. So is COPD really a problem? Should we worry about it? What is the prevalence and the burden of COPD? In 1990, COPD was the 6th cause of mortality. However, in 2020, it's projected to be the 3rd. So it's really an advancing and increasing cause of mortality. And you see this data, which published in The Lancet, which proves that this is what we expect to increase. Now, what about the death rate and age adjusted over the years from 65 till now with the advances in medicine? We see that overall there's a 7% decrease in all causes mortality. And from cardiovascular mortality, which is really the highest cause of mortality, there's a drop by 62%. However, for COPD, it's actually an increase of more than 160%. People can attribute it to multiple reasons. The population are getting older, we're surviving other diseases. In whichever way you want to explain it, the mortality from COPD is significantly increasing. It's more interesting that earlier on, we used to believe and know and even have data to prove that this is a disease of the male population. It's a male gender disease, but that's not the case anymore. And in 2000 was the first year whereby the female or the women mortality exceeded the men's mortality. And this is, again, as we expect, because 20 years ago, it became more socially acceptable, for ladies and women to start smoking. Do we really know the impact of the disease, and do we know exactly the prevalence? There were some studies, some initiatives done to do population screens and look really what are the incidences. And this is the BOLD, not the GOLD, and not the BOLD, which is the Burden of Lung Disease Initiative. Participants were about 12 sites, around 9,500 patients or people, regular people were screened. And they went through testing and through questionnaire testing and through spirometry. And they looked at COPD risk factors. And we found that in different populations, there was about 11 to 26% prevalence in the general population to have stage 1 disease, and men more than women. However, this prevalence was distributed differently among the population. The prevalence of stage 2 or higher was about 10% overall, around 12% in men and 8.5% in women. However, the doctor diagnosis of COPD was reported only in 5.6% of the participants. So in this population, around 95% of the diagnosed COPDs actually with stage 2 or higher were missed. Over 15% of COPD occur in never smokers. And this is mostly in low-income nations whereby you have more toxic fumes and toxic fuels for combustion used. But 85% remain because of smoking. And the overall pooled adjusted odds ratio for stage 2 or higher COPD is about 2 for every 10 years increment. So every 10 years of aging, the risk of developing COPD becomes 2 times higher. And this is what you see in the prevalence study in Latin America. You see that this is the prevalence depending on the area which was sampled. If you are between 40 and 50, between 50 to 60, it doubles, and then it goes more. If you're 60 also, it doubles. The odds ratio is around twice. In the Platino study in 5 Latin American cities, around 89% of subjects with COPD had not been previously diagnosed, which is commensurate with the 95% almost in the prior study. And these data prove how much underdiagnosis and misdiagnosis is being replicated around the world in Europe and in Latin America. Now, is it really a disease of the elderly alone? In this study, they looked at younger population, 20 to 44 years of age, and you saw that around 1% of that population had stage 2 to 3, where 3% have stage 1, and stage 0 was around 12% of the younger population. Now, does COPD affect only the lungs? Of course, the answer is no, and everybody expects this. So COPD have a systemic effect, and there are extra pulmonary complications and symptoms. So COPD is now recognized as having both local lung and systemic effects, and the mechanism of some systemic effect is not yet well understood. However, there are serum biomarkers measured by protein microarrays, and I'm going to get to the protein microarrays later on, and they identified patients with COPD that have related clinical phenotypes, such as the extent of the airflow limitation, 6-minute walk distance, exacerbation frequency, and Bode index. These were actually phenotypically and genetically marked in some patients. So COPD patients are at risk of developing comorbidities, which of course affect their general outcome. They're at higher risk of developing myocardial infarction, angina, and atherosclerosis in general. And some studies have shown that the pulse wave velocity, which is a measure of vascular elasticity and vascular response, mostly in the aorta, was actually affected immensely in COPDers and also correlated with inflammatory markers in COPD. Osteoporosis, and this was proven even in men, regardless of the intake of steroids, whether systemic or inhaled. Respiratory infections, depression and anxiety, it can reach up to 90% in COPDers. Anxiety can reach up to 20% in some studies. Diabetes and lung cancer. COPD has significant extrapulmonary effects, including weight loss, and we know that cachexia negatively correlate with survival. You have nutritional abnormalities, and you have skeletal muscle dysfunction. The skeletal muscle dysfunction has been postulated originally being because of respiratory failure, inability to deliver oxygen to the muscles, but that was refuted in multiple studies. And some studies even went to the fact that muscle biopsy were done and showed that there is a decrease in the mitochondrial content, and there is a mitochondrial dysfunction in the COPD patients. Again, people who have a higher muscular dysfunction had a worse outcome in COPD, and the quadriceps muscle strength predicted mortality in patients with moderate to severe COPD. So the weaker they are, the higher the likelihood of them dying in a shorter time. In this graph, you'll see the direct correlation between the quadriceps strength and the FEV1. So even it correlates with the degree of severity, not only with the outcome. So what about mortality? Patients with COPD die mainly from extrapulmonary diseases, and COPD-related mortality is probably underestimated because of identifying the precise cause of death is difficult in the elderly due to multiple comorbidities, including the heart disease, arrhythmias, cor pulmonale, PEs. But it's interesting that in one of the studies, 25% of patients admitted with COPD had actually pulmonary emboli detected, and it wasn't really a cause-effect clear ratio whether what caused what, but this was an association proven that 1/4 may have actually concomitant pulmonary embolism. So we know that the mortality from COPD is around 1/4 because of cardiovascular disease, 1/4 because of cancer, a little bit more from pulmonary diseases, and the rest is divided into other causes. So what are factors that are associated with the risk of mortality? You know, we always followed COPD as an FEV1 and a static number which dictated or stratified patients, but more studies have showed that there are more to that. So you have the FEV1 as a form of obstruction or a surrogate for the obstruction measurement. You have the body mass index, you have the dyspnea symptomatology, and you have the exercise capacity. Now these together will show us also that there are risk factors for COPD mortality, including the health status in general, recurrent exacerbations, and the presence of comorbidities. So typically, a COPD patient will actually develop some airflow limitation, breathlessness, which is worsened immensely by exacerbation. The patient will have limited exercise capacity, which will cause to more deconditioning, more breathlessness, and the patient will fall into this vicious cycle, leading to poor health-related quality of life, disability, and even death. And as we mentioned before, and we're going to continue mentioning, and I'm sure in the coming years we're going to be hearing a lot about that, the role of exacerbations in actually worsening the outcome of COPD. We know that exacerbation reduce quality of life. We know that they accelerate the decline of FEV1. They increase the health resource utilization and cost, and they increase mortality with exacerbation hospitalization. In this study, actually, in 2003, we see that patients who had one exacerbation and then started recovering, and over the coming 26 weeks, i.e. the 6-month period, people who had a recurrent exacerbation, a subsequent one, had a plateauing and not so much improvement in the St. George Respiratory Questionnaire. So people will do worse in terms of quality of life if they get a repeated exacerbation. Again, if you look at survival, we know that people who have no exacerbation has a better survival compared to recurrent exacerbations. So again, we are always looking beyond the FEV1, but you cannot ignore the role of that parameter and the role of the spirometry and the pulmonary function test measurement to estimate and prognosticate based on obstruction. So we have the commonly used before the goal 2011 strategic staging within the mild, the moderate, the severe, and the very severe one. We look at the BOD index. As we know, we have the body mass index, the obstruction, the dyspnea, and the exercise. And these, if put together in a composite score, you'll give a scoring for the FEV1 and the degree of obstruction, for the distance walks in 6 minutes, for the modified MRC, and for the body mass index. And then the highest the patient score, the worse is their outcome. That was the postulate. But again, was this validated? Let me give you a clinical story. These are 4 real patients that we knew, that I personally knew and took care of. And they all share one common factor, which is really an FEV1 less than 35%. For the sake of the presentation, I'm going to give you the data on 2 of them. Patient 1, the one at most on the right, has an FEV1 of 28%. His MRC is 2/4. He could walk 540 meters in 6 minutes. His BMI is 30, so his BOD is 3. Pretty low BOD index. Patient number 4 had actually FEV1 of 34%, even better, but his MRC was 4. He walked only 154 meters, and his BMI was 24, so his BOD was 9. Now guess who outlived who? Okay, this man died around 6 months after this picture was taken. Well, I left the US, he was still alive, I'm not sure. So we looked back to see if really BOD improved prognostication in terms of survival. And if you look at the ATS criteria, which only looked at FEV1 severity, you see that that doesn't differentiate much the population. A COPD in your clinic wants to know if you can predict for him his outcome, his survival chances or mortality risks. However, if you look at the BOD index divided in 4 quartiles, you see that between quartile 1 and quartile 4, which was the example of the 2 patients I mentioned, there is actually a huge gap. So BOD index did really predict better the mortality and the survival. We know that it's not just about having obstruction because of bronchospasm. You have inflammation, which is due to multiple factors. You have the neutrophils, the monocyte, the macrophages, the tumor necrosis factor alpha, interleukin 8, leukotriene B4, oxygen-free radicals, CD8 infiltration, proteases, anti-proteases imbalances. So, and I'm sure we're going to discover much more or other pathology and pathophysiologic pathways. So if you look at the COPD, you know that in the airways, you will have actually more neutrophils, more macrophages, more CD8 plus lymphocyte, elevated interleukin at TNF-alpha, and you have mucosal edema. And then if you look even at the sputum inflammatory cells, you see that the neutrophils actually are much higher in COPD compared to healthy subjects. And these are actually patients who are not an exacerbation. These are stable COPDers. You also see that if you look at the COPD, the gold, again, the old gold stage, from 0 to 4, you see that there is an incremental increase, less of evident on the CD8, but with the worsening stage, there are actually more infiltrative cells and you have more inflammatory markers. Again, which was interesting is that the number of neutrophils, or the percent of neutrophils in the airway, or in the sputum actually, correlated significantly with the rate of decline of FEV1. So the more neutrophils are in the sputum analysis, the more likelihood of a rapid progression of the COPD. Again, we know that during exacerbation, even this number of neutrophils is significantly increased. And that goes also for the interleukin and the other inflammatory markers. Interleukin 6, for example, in exacerbation, it's increased, and then it goes down as the patient gets better and gets discharged. The same goes for interleukin 8, and the same goes for leukotriene B4. So they all get up in exacerbation, and then they taper down as the patient gets better. CRP, interestingly, and this is actually a marker that we know now cardiology love it, and they look at it very aggressively to prognosticate even acute coronary syndrome recurrence and relapse. And we see that in COPD, even healthy COPD, healthy in terms of non-exacerbating or stable COPDers, actually it is significantly increased compared to controlled, which are smokers or non-smokers. So it is not increased by the smoking exposure, really, but by the fact of having the inflammatory reaction. So, like any destructive disease, there is an imbalance between the oxidative factors and the anti-oxidative factors. And if the balance tips toward the oxidation, we all know that you're going to develop COPD, emphysema, and bronchitis. You have also mucociliary dysfunction. You have more mucus hypersecretion, increased mucus viscosity, reduced mucociliary transport, and more mucosal damage. So the epithelium is very distorted. Again, there are some structural changes. You have more alveolar destruction, epithelial hyperplasia, glandular hypertrophy, goblet cells metaplasia, and airway fibrosis. And you see that, the really metaplasia and fibrosis and the hypertrophy of the epithelium in COPDers. Again, the bronchospasm is not the same as in healthy airway. It's much more narrowed and much more inflammatory. And this is due also to the worsening or increased smooth muscle contractions, increased cholinergic tone, increased hyperactivity, and loss of the elastic recoil and more inflammatory structural changes. Some other systemic component, you have systemic inflammatory poor nutritional status, such as the reduced body mass index, impaired muscle, skeletal muscles, such as the weakness and wasting even of the muscles, impact on other organs, such as the cardiovascular system, as we mentioned. So all of these come together to make really the COPD or patient having a worsening outcome by declining lung function, worsening symptoms, increasing exacerbations, decreased tolerance, deteriorating health status, and eventually mortality increase. So I promise you I'll go back to the microarray. I'm going to talk about it because that's an interesting thing, and I'm sure my friend Dr. Shami is very well versed in that, since a lot of the work was done by some of his colleagues. Microarrays actually is when you extract lung tissues and then you crush them and then you run them over a chip which has multiple, I'm talking about thousands of wells, which has RNA probes. And then by the detection of the protein run on them, they will tell you the amplification or what are the proteins expressed in this tissue. And these studies actually were done to look at the risks of COPD and the risks of lung cancer and other risks in the lungs. Of course, here we're going to talk about COPD. And this is what comes out if you go and you plan this. Each dot or each color represents actually a gene expression in the tissue. And we see that in general, guys, to make it simple, green is good, red is bad. And this is not political, this is here. So here you have the genes which are red are much more expressed in the mild or no COPDers compared to the advanced COPDers where you have more amplified genes which cause more lung destruction. So there is a genetic predisposition, and this is only amplified by external exposure such as smoke or otherwise, and these correlate actually with the severity of COPD. So there are available strategies for managing stable COPDers. There are smoking cessation, bronchodilators, whether beta agonist, long or short-acting, anticholinergic, long or short-acting, inhaled corticosteroids, vaccinations and immunizations, pulmonary rehabilitation, long-term oxygen therapy, and lung volume reduction, whether surgery or endoscopically. So what are the objectives? You want to relieve the symptoms. You want to improve exercise tolerance. You want to improve the health status. You want to prevent and treat exacerbations. You want to prevent and treat complications. You want to reduce mortality, and that's been a big focus of a lot of the trials and the treatment strategies. You want to minimize side effects from treatment, and you want to prevent disease progression, which also has been the goal of so many interventions and treatment strategies. In general, I would say that the more the FE1 declines and the more the symptoms get higher, the more amplified the treatment is. Now, if we talk pharmacologically, what comes before what, this has been reassessed and the order has been replaced in the GOLD guidelines 2011. So how was the things up till 2010? Basically, you classify the patient mostly on his spirometric functional status, and then you would advance treatment accordingly. We'll go back to that in a bit. Now, smoking cessation. Smoking, the single most effective and cost-effective intervention to reduce the risk of developing COPD and to slow its progression. That's the only disease-modifying intervention that is solidly proven and accepted. And I think the majority of us, if not all of us, are familiar with this graph where you see that people who actually never smoked or non-susceptible smoker, they lose lung function steadily after the age of 25 at a lower rate. However, smokers or susceptible smokers will lose at triple this rate. And if somebody stops smoking at any time, he will go to follow the slope of the actual non-smokers. And in this study, this was revalidated looking at people who have been diagnosed with COPD, who remained quitting smoking, who continued to smoke, and who have intermittent quitters. And you see that over time, there's a difference in the rate of decline, being, of course, the best if people quit smoking. Well, if it's better if they're intermittent than if they're continuous, but it's not that great anyway. So this is the most frustrating exercise to convince somebody to stop smoking. Okay? I'm sure the majority of our patients do not want to hear about it because they think they know and they can't, and that's it. They want to close the door. They want you to help them with medication, with anything else, but not to talk about smoking. However, it was proven that if the physician keeps on mentioning it, even for a short time, up to 3 minutes on discussion, that actually was correlated with an improved smoking cessation by up to 10%. Yeah, I know it's not great, but 10 is better than 0. So if you keep on reminding your patient and talking about it, even for a brief period in each visit, there is a good chance, 1/10, that your patient may be convinced and will actually quit smoking. If counseling fails and the patient is really willing to take this effort and this step, there are numerous effective pharmacotherapies which are available in the market nowadays, and we can resort to them to help smoking cessation. And this slide will prove that the more you talk about patients, now good luck talking for an hour and a half with patients about smoking, but if you do it more, you will actually achieve a more chance of them quitting and sustaining the quitting smoking. What about inhaled bronchodilators? As we know, they are the main stem of any treatment we give for COPDers, and they improve airflow and hyperinflation. and they decrease the work of breathing and improve exercise tolerance. Now, it's interesting that looking at the systemic effects of COPD, and there was lots of work done looking at the inhaled steroids and its role in that arena. And we see that the post-hoc analysis in the EUROSCOP suggested that long-term inhaled steroids lowered the incidence of ischemic heart disease in patients with mild COPD even. And this is supported by other retrospective database studies and by previous studies suggesting that ICS may reduce systemic inflammation in patients with COPD. Now hold your breath, we're going there. However, the appropriate role of inhaled steroids in COPD is controversial still. We have to accept that. People advocate that it should not be given. People are strong proponents for that, so the jury is still out. However, there are studies have shown that the inhaled steroids do not substantially modify airway inflammation in COPD and may increase the risk of pneumonia. It's very important, guys, if you want to evaluate your patient, to risk stratify and see what fits this patient best. Yes, there may be some increase in pneumonia. There may be some osteoporosis risk. As we said, osteoporosis can happen even without the steroids. There definitely is a risk of oral candidiasis. But you know, the benefit of decreasing exacerbations and possibly improving quality of life, in my opinion, and in a majority of patients, not all of them, of course, outweighs the risk. So you have to look at really what makes your patient better. If he never had an exacerbation over the past 3 years and he's okay, you may argue that this is not needed and this is something convincing. But if you need to decrease exacerbation because one exacerbation can outweigh any risks beside a fatal pneumonia, which is something else. What about long-term oxygen therapy? We know that increasing survival in appropriate patients, so patients who are hypoxemic, and may also improve hemodynamics, hematologic characteristic, and exercise capacity. You need to select your patient. Usually they are advanced COPDers, and they have to be hypoxemic while awake, at rest, not only with exercise. The recommendation after the Medicare study was having PO2 of 55 or lower, or saturation of 88% or less. However, if you have end organ involvement, end organ dysfunction, such as respiratory failure or right heart failure, you would actually prescribe oxygen at a higher threshold, even saturation up to 90%. What about short burst of oxygen? Just use it as needed. It is widely prescribed in patients with COPD, although with little evidence of benefit, and might shorten the recovery time after activities of daily living, though it was only proven to shorten it by seconds. So it was like 20 seconds versus 38 seconds. There is a 20-second gain if used in the burst method. There are some other novel therapies now in the market. Well, infliximab as a TNF-alpha antagonist was shown actually not to improve the quality of life, nor have any effect on FEV1 6-minute walk distance, nor to reduce exacerbations. At the same time, it was associated with an increased risk of pneumonia and cancers. So that I'm not sure it's going to make the market to be given to our patients in COPD. Other novel therapy, there's roflumilast, which came to the market also, and it showed that there is no benefit really in terms of exacerbation in the general population of COPDers. However, there was an unintended but measured improvement in respiratory function. But if you risk stratify your patient and you select a patient's group who are actually higher exacerbators and they have bronchitic, more phlegm production and advanced COPD, there was actually a significant improvement in the rate of exacerbation in this particular subset of patients. What about statins and COPD? Now we give statins for everybody. So it's a new vitamin. So animal studies have shown protection against the development of smoke-induced emphysema. So they have some antioxidant effect on the lung. And they may decrease both the local and systemic anti-inflammatory effects. And they're also shown to reduce cardiovascular mortality and may therefore protect against the increased cardiovascular risk that is known to occur in COPDers. These are all done retrospectively to prove that they do have an effect on the general population. Statins treatment was associated with slower rates of decline in lung function in the elderly subjects. These are non-COPDers, but elderly subjects, they actually have a slower rate of decline in their FEV1. So could this be a disease-modifying drug? I think randomized clinical trials are warranted, and we need to see this in the coming future. What about lung volume reduction surgery? It's an alternative for selected patients with severe inhomogeneous emphysema who remain symptomatic after optimal comprehensive medical therapy. LVRS improves FEV1 by close to 10%, but there is a larger improvement in exercise tolerance, dyspnea, and health-related quality of life. But that is not for all the patients. The NET trial showed that the patients who benefit the most are patients who have reduced exercise tolerance and predominantly upper lobe emphysema. And an ideal candidate would be somebody with an FEV1 between 20 to 35%. There was a significant increased post-surgical mortality in people who have less than 20% FEV1 or less than 20% diffusion capacity. So diffusion capacity would be more than 20% of predicted. Patients who have hyperinflation and limited comorbidities. Now, what are the available pharmacotherapy now beyond the short-acting beta agonist and the short-acting muscarinic antagonist? We have the ICS-LABA, we have the fluticasone salmeterol, the budesonide formoterol, we have the long-acting anticholinergic, we have the tiotropium, and we have the newly FDA-approved aclidinium. We have the ultra-LABAs now, we have the endecaterol, we have the PDE4 inhibitor, the roflumilast. Now, in 2011, as we said, there was a new GALD guidelines came out, and they a little bit revolutionized the way we look at COPD patients and how do we risk stratify them in order to plan our best targeted therapy. So now the COPD include assessment of the risk of exacerbation in combining symptomatic and spirometric functions. We're looking at previous exacerbation during the last 12-month assessment. So it's not only about spirometric function in classifying patients. So we moved from the GOLD stage 1, 2, 3, 4 to now A, B, C, D. Now in general, A is less symptoms, low risk. B is more symptoms but remains low risk. C is less symptoms and high risk. And D is more symptoms and high risk. We're going to look at the table in a bit. Treatment options now are classified to first choice and second choice or alternative choices. So now in 2011, we moved more to have really a focused approach and to have a more illustration that we need to relieve symptoms, improve exercise tolerance, and improve health status. This is by reducing the symptoms. And we need also to reduce the risks by preventing disease progression, prevent and treat exacerbation, and reduce mortality. If you look in the prior recommendation, they are all there. But this was not really put in a focal and a focused and really emphasized approach that is increasing our interest in really being more aggressive in treating our patients. In terms of assessing the symptom, there are two main ways which have been advocated. You have the CAT, the COPD assessment test, and you have the breathlessness measurement by using the Modified Medical Research Council questionnaire. For the CAT, you have 8 parameters, and you score from 1 to 5, 1 being the best, 5 being the worst. You have having cough, phlegm, tight chest, breathlessness walking uphill or up the stairs, breathlessness with daily activities, confident leaving home and walking around, sleeping well and comfortably, and having enough energy to carry whatever exercise they want to do. Then you score them, and the least you score, the better you are. The scores are divided to 4 quartiles. You have 0 to 10, 10 to 20, 20, 30, 30, 40, and again, the highest it gets, the worst it is. The other one is the MRC, the Modified Medical Research Questionnaire, and you see it's clear. You grade 0, I only get breathlessness with strenuous exercise, which I hope most of us are. Grade 1, I get short of breath when hurrying on the level or walking up a slight hill. Well, I am 1. 2, I walk slower than people of the same age. And then 3, I stop for breath after 100 meters. 4, I'm too breathless to move around. Okay? So you classify this, again, as another way of measuring symptomatology. Then you put the quartiles, and as I said, you look at this symptomatology. So having MRC 0 to 1, a CAT less than 10, CAT more than 10, and MRC more than 2. And in terms of the risks, you have the GOLD classification in terms of flow limitation. You have the A and the C, and you have the exacerbation risk. And again, A is somebody with low risk and low symptoms. D is somebody with high risk and high symptoms. C is high risk, low symptoms, and B is high symptoms, low risk. So based on this, you're going to look at your patient, and you're going to try to go through this table. These are put as first, second choices. And the real change from before is that now we are more aggressive to introducing the combination treatments earlier on. okay, in patients who are actually having less symptoms and high risk, and having high risk and more symptoms that was used before, but for the class C, this is actually new. So now we can use it more in class C. In the alternative treatment, we're even much more aggressive now. We add a lot, we throw the book, as we say now, okay? We're more aggressive, and we include the PDE4 inhibitor at this stage. This will illustrate the same first and second choice as the prior slide, but will also add to you the alternative choices, having theophylline among them, and having also the PDE4 inhibitors and the theophylline as well, including the carbocysteine in the actually class D. So what are the barriers to adherence with therapy? Now, it's very easy to give therapy and expect patients to do well, but some barriers are related to therapy itself, some other barriers to patients themselves, and the third one is related to us. Now, the first related to the treatment is, the purpose. It's hard to tell somebody you're going to take this medication for the rest of your life, but that will not improve your survival. That will not improve in terms of how you're going to be worsening, but you will feel better. So if he feels better, he's going to stop it. He's not going to take it. So it's hard for us still to sell to our patient or to emphasize our patient that there is actually a long-term benefit. It's not only about symptomatology. Okay, so this is why we need really to change our paradigm now and push more on that level, because decreasing exacerbation, improving quality of life are actually very important parameters. The duration of as I said, the onset of treatment, some of the treatments do not feel an immediate recovery, and they will go to use the short actings instead. The cost, of course, and the complexity, especially when we talk about different inhalers and different methods and different ways of administration. In this slide, we see that, and this is not even in Lebanon, you see that there is actually an increased cost as the patient gets sicker. And this is normal. That applies, to any disease, especially in cardiovascular disease. But, cardiologists are much smarter than us. They can give a statin even if they decrease 4% the risk of their complication. They can convince people much easier than us. If you give any inhaler and the patient is dying from COPD, but he had one PVC, the cardiologist can tell him, stop the inhaler, he will stop it. I don't know why, but they're smarter. If you look at the inhalers, you see how complex these are, and there are different types I picked, and these are only the bronchodilators. I didn't go to the other, methods or other devices that we can use. It's complex. And unfortunately, we live in a society whereby the pharmacist, or at least most of the pharmacists, do not either know or have the will to explain to the patient the modes of delivery and how to use. So we end up doing it ourselves in clinic. And if we are in a rush, sometimes we miss doing it, or we do it in a rush, and the patient doesn't get really the way to acquire the treatment. Now, improving COPD management have two things. There are the easy stuff and the hard stuff. Now, the easy stuff is to prescribe, write for them to take O2, write the medication, and they leave. The hard stuff is to stop smoking, using inhaled medication and O2 as needed, but optimally as continuous as much as possible. Pulmonary rehabilitation, which, as we all know, is something we lack immensely in Lebanon. Navigating the healthcare system and the cost of treatment, ومعبي وراء وعبي فورمز وبعته وجيبه وما بنغطيه هلا ومغطيه بعدين وكل شهر بنجدد روشتة. That's something really more difficult for patients and for healthcare workers. Now I need to ask a question after this talk. What do these patients have in common? COPD. What else? Anybody has an idea? Well, one thing. These patients have COPD who never had spirometry. Okay? You can get 6 echoes in 1 year, 4 cardiac cath in 5 years, because the cardiologists think it's a must. But not even a spirometry to diagnose COPD, and you are on treatment for COPD, and it's so much evident. These patients, after they did better, they had spirometries done, and look at the numbers. 24% of predicted, 31%, and 29%. They are severe and very severe COPDers. So the myth is that the disease has no effective treatment. The reality is that COPD responds to treatment. With good care, the patients will get better. The prognosis has improved over the years and with our more aggressive approach. So in summary, COPD is a progressive and systemic disease. Pathophysiology is ongoingly being exposed. Promising newer pharmacotherapy, changing treatment concepts and endpoints. We don't know where the future is going, but we definitely know that smoking will kill anybody. Thank you.
on time. Thank you for this excellent lecture, Salah. Is there any questions? Yes.